afternoon, everyone. My name is Bridget Retta, and I'm an analytics architect at Qventus. I'd like to start by thanking you for attending today's session, showcasing how Qventus, powered through Looker, was able to help hospitals plan through COVID-19. Before we talk through the agenda and jump into the presentation, I'd like to share a brief background on Qventus for those of you who aren't familiar with our company. So we're the first patient flow automation solution for healthcare, and we take modern innovations in AI and machine learning, behavioral science, and operations management, and we apply them to hospital operations. We've got a long and proven track record with over 120 successful deployments across US and Canada, and in a range of organizations, which include large health systems, academic medical centers, and community hospitals. We're helping our partners achieve really transformative results, up to 0.8-day reductions in inpatient length of stay, 15% and more decreases in ED length of stay, 23% lower PACU exit delays, and a lot more. We help enhance the lives of frontline teams, increase the value of your EHR, and improve the quality of care. Okay, so today we're going to kick things off with discussing at a high level what challenges we saw and heard hospitals were facing throughout the pandemic in the first half of 2020. Then we're going to go through how we were able to develop two of our COVID-19 tools, our PPE, which is a personal protective equipment, and PAC planner. PAC standing for Post-Acute. I'll close off with a demonstration of the tools and my personal experience working with hospitals and how they were able to gain insights. So let's get started. Well, there's no question that the first half of 2020 has been unparalleled. As we're all acutely aware, the pandemic has caused enormous disruption in numerous areas. It's caused significant losses in jobs, it's affected the health of our coworkers, and not to mention the ongoing toll on patients and communities across the country. For hospitals especially, though, it's created unprecedented financial pressures. We have been seeing canceled surgeries and the economics of COVID patients and increasing COVID-19 hospitalizations. And so that's brought forth capacity pressures on our health systems and increased demand for appropriate PPE supplies at the right time. And so Qventus responded immediately. At the onset, our team developed a localized COVID-19 model and scenario planner that essentially predicted total impact on each hospital and health system. And it drilled down to a specific hospital or facility level using real-time local data. So we had information on daily cases, populations, age cohorts, bed supplies, occupancies, week over week. And so that tool consisted of 450 localized epidemiological models that are run and updated daily and providing an up-to-date perspective on the impact of the pandemic in local areas. Essentially, we basically had a daily prediction of how many COVID-19 patients were coming through the door of just about every hospital in America. From there, we built 3 custom planning solutions, 2 of which were entirely in Looker, that I actually co-developed and will be demonstrating shortly. We chose Looker because of the flexibility it afforded us, and mostly the ability to rapidly scale and quickly implement versus our other options at the time. The speed to getting the tools in clients' hands were super important to us. So in Looker, within the 2 planners we had built, we sought to help hospitals answer 2 very important questions. The first one, will we have enough PPE to equip staff given increased consumption and shortages? And 2, how can we efficiently discharge patients to post-acute care given capacity constraints? Our first challenge was determining how much PPE supplies a hospital had. I actually was working at a hospital prior to starting the development of these COVID-19 planning tools, and I found a lot of hospitals had resolved to the same solution, counting inventory every day and extrapolating on how long it would last based on the difference from yesterday. The problem is usage today doesn't equal usage tomorrow, and with so many moving parts too, of course. We wanted to find a better way, as it was paramount to be able to help hospitals understand the impact of reopening surgery rooms and adjusting supply usage policies. And with conservation decisions being made, hospitals had to decide how much of each PPE type would be used. And of course, as we know, usage varies by department and type of supply. So using gloves in emergency, you'd be interacting with a patient, and every single time you saw a patient, you'd have to change those gloves. All of those things had to be taken into consideration. And so, leveraging our localized SEER epidemiological model that took inputs from our elective surgery planner as well, our solution was a hospital-wide PPE usage forecasting tool. Given hospitals highlighted specific supplies being the most important, we included forecasts for gloves, gowns, N95, surgical masks, ear loops, face shields, and of course, COVID tests. So being able to model complex usage of supplies in a hospital is super difficult to do, let alone be able to customize. We initially started out with a shift-based and case-based supply usage, but with the ability to continually change and test assumptions using Looker's functionalities, and based on feedback from our clients, we evolved constantly to showing usage by interaction and by type of patient as well. So in the examples you'll see here on this slide, you can see on the left-hand side the LOOKML. So LOOKML is Looker's development syntax language, and that showed interaction-based usage. LOOKML provided the ability to use constants based on known experience in hospitals. So you can see in navy blue there what we had developed as providers on shift. Also, the ability to reference calculated fields we defined, as you can see in purple, basically the nursing shift length, and even use user-entered parameters. So hospitals could actually go in and enter things, and it would of course adjust the model. And you can see those parameters within the curly brackets. We repeated this process for all other types of supply usage and even built calculations on top of the LOOKML. So on the right-hand side of the screen at the top there, you can see the green columns on the chart. After we developed all of our complex calculations, we developed another layer of calculations on top of that to calculate usage. So after building the initial metrics and measures we wanted, we could create any amount of layers on top to handle these complex calculations and aggregations. And again, you can see the N95 supplies we calculated and how much would be used and what would be reprocessed within the day. The result, as you can see in the bottom right, a clean visual to show hospitals on a daily basis how many supplies were being used across the hospital and which areas they were used, inpatient units, ED, and OR. The level of customizability and ability to easily change and alter assumptions on the fly was super important while continuing to develop new and more robust versions. Our second challenge was determining how to efficiently discharge patients to post-acute care given capacity constraints, so essentially when a patient had left the hospital. Skilled nursing facilities had capacity constraints of their own, and hospitals were increasingly aware of the need to determine how to ensure they were going to efficiently discharge patients to the appropriate and safe next step in care. During COVID, facilities didn't know what to expect with extremely limited visibility into each client, and the challenge was really to identify any potential capacity constraints. So to solve this challenge, we started again with our localized SEER epidemiological model, as well as third-party information and published research we discovered. And our solution was a local hospital region-wide insight into those capacities. Hospitals could now see on a daily basis how many COVID-19 patients they would likely need to discharge and where they could possibly route those patients. So with post-acute care, we had yet to access a plethora of information that was made available publicly. And using Looker's ability to leverage multiple sources of information, we were actually able to pull all these publicly available data sets with ease through BigQuery. And this enabled more robust modeling and ease of data access for multiple complex calculations in Looker. So we could then adjust each metric based on if the data was available or not, with simple SQL statements in Looker. So users had the option to override assumptions if they didn't feel our assumptions were unique to their situations, or else information would just default to the assumptions we made based on our publicly available data sets and other data sources. So using all these data sets, we could pinpoint when we expected a capacity constraint in post-acute facilities. A quick note on how we were able to get this to our clients, who we were working with to build our tool, and the general public engaging with us to use these tools. Well, at a high level, we've already discussed all the different sources of information, which includes the boxes you see on the left that we ended up having to pull into our modeling engine in Looker. Our data sources included things like our COVID-19 SEER model, third-party data sets, and so on and so forth. Using this information, Looker became our modeling engine where we created, iterated, tested changes, and using all the capabilities I've already described, built the PPE and PAC tools. From there, we were able to deploy to specific client instances. And just so you're aware, each client had their own instance to ensure their data and information was kept as isolated as possible for utmost privacy. And for all new clients and people that were engaging with us to use our tools, we were scaling quite rapidly to show information we used as a separate public Looker instance to ensure no impact or changes to our existing client instances from a privacy and technical standpoint. And now we're going to go into our demo. So as we talked about, this is actually our localized SEER model that we built our Looker tools on top of. So on the left-hand side, users can enter all the assumptions that are unique to their situation, and they can find out on a daily basis what the census of COVID, ICU patients were, and so on and so forth. We also have a surgery planning tool, which is another input into our models. But let's get right into the PPE. So again, on the left-hand side, you can see all the assumptions that a hospital can change if they want to, or else it'll default. And within the tool, you can see at the onset how many days remaining of supply you have left between masks, gloves, gowns, shields, and tests. And within each supply, how many days remaining that supply will last, and what area that supply is expected to start depleting in. So in the inpatient, ED, or OR areas, and similarly, what that projection looks like overall for the different sizes of N95s. And we did this for every single one of the supplies you can see in the top. And so you can see and project to the end of the year how many supplies will actually last based on your unique situation. And the post-acute planning tool showed you, again, based on our localized model, how many daily discharges there would be for COVID and non-COVID populations, and out of those populations, which ones would actually be discharged to post-acute care. And you can see the different types. So home health, SNFs, aka skilled nursing facilities and others, and on a weekly basis what that actually looks like. So I'll scroll down to the bottom here. This is the capacity chart where you can see, in this example, there is no capacity constraint expected, but that again is based on the assumptions on the left-hand pane, which you can adjust. And at the very bottom, we've showed the actual skilled nursing facility capacity that is available. So again, all of these tools between the PPE and PAC were built within Looker, and we were able to embed into our own application. So the results so far have been great. We spent a lot of time building and working with clients to use the tools, and sometimes we forget to take a look back and see what happened. In an unprecedented time, we were able to engage with clients like never before, working alongside them to solve their problems as they were facing them. For one PPE client we work with, it helped provide stronger justification to make larger PPE purchases. And for PAC, we're currently working with a larger long-term healthcare system to identify potential capacity constraints that they should be aware of given the changing COVID conditions. And so far, their feedback was, as you can see on the slide, we use the model as a core part of our COVID planning strategy and are very happy with the results so far. We're actively using it to plan for potential surges this fall and winter. So really excited about the fact that hospitals continue to use it, and over 1,100 facilities are using it today. Again, we're really thankful in this time of this crisis that we were able to help rapidly develop and deploy tools that continue to help our clients address some of their most pressing issues. Thank you so much for spending your time with us today, and hope you have a great day.